Hello, everyone. I welcome you all and our esteemed speaker, Dr. Adarsh Kumar, in today's session on solving ORO-dental challenges in small animals, practical tips, and advanced techniques for effective management. I'm Dr. Vishal Sharma, a proud veterinarian and managing director of Oriheal Lifesciences. As a practicing vet myself with two clinics in North Delhi under the name of Pets Planet India Pet Clinics, I truly understand the challenges and aspirations of our veterinary community. It is with immense pride that I share a significant milestone with you all. Oriheal Life Sciences is now one of the India's leading and largest manufacturers of veterinary pharmaceuticals range. Oriheal Life Sciences is a company built by a vet for the vets. At Oriheal, our core philosophy is simple. We exist to serve our fellow veterinarian. Every innovation, every product, and every initiative we undertake is dedicated to empowering Indian vets and elevating the standards of veterinary practice in our country. Our product range considers safety and innovation first. We offer an extensive portfolio of herbal medicines, which are India's first 100% safe, sugar-free, and free from side effect products, making them ideal even for newborn puppies and kittens. Nutraceuticals, pharmaceuticals, injections, and grooming products are meticulously formulated to enhance the well-being of pets. Considering our groundbreaking innovations, we take pride in being among the first to introduce meropenem injection for veterinary use, ferropenem tablets, alprazolam suspension, tramadol suspensions, furosemide suspension, and mirtazapine suspension with a long list of other products to the Indian market. A comprehensive range of neuro, cardiac, ophthalmic, and dermatology medicines, ensuring you always have access to cutting-edge treatments. What is Buy a Vet for the Vet's mission? We firmly believe that education is the backbone of progress. To strengthen the veterinary profession in India, we have built one of the largest online platforms dedicated to continuous learning. Through this initiative, we regularly host expert-led webinars on specialized yet unexplored topics like neuroscience, cardiology, ophthalmology, and radiology, and today's session includes dentistry. Because at the end of the day, knowledge is the greatest tool in saving lives. We request you to join us in this journey as veterinary practice in India is evolving and we must evolve with it. Oriheal Life Sciences is just not a company, it is a movement, a collective effort to uplift the small animal practice in our country. We invite you to be the part of this mission to advance veterinary education, to enhance our industry, and the most importantly, to ensure a healthier future for the pets we serve. Let's work together, learn together, and grow together. We need your support. Any big and small support acts as lifeline to us. Another milestone is achieved today as we proudly present today's webinar series on solving ORO-dental challenges in small animals. This is a first of its kind webinar series from Oriheal Life Sciences about small animal dentistry. Now I would like to invite and introduce our esteemed speaker, Dr. Adarsh Kumar, to you. Welcome, Dr. Adarsh Kumar.
Thank you, Dr. Vishal.
Dr. Adarsh Kumar, a distinguished professor of surgery and head of the teaching veterinary clinical complex at the Veterinary College, Palampur. With an illustrious career spanning over 28 years, Dr. Kumar has made remarkable contribution to clinical teaching, research, and institutional development. His expertise has been instrumental in advancing anesthesia and critical care, diagnostic imaging, dentistry, and soft tissue surgery. His international expertise includes a tenure as a visiting professor at the University of Tripoli, Libya, where he worked in a university equine and companion animal hospital. Notably, Dr. Kumar pioneered the Admit pin, a widely used orthopedic implant for managing long bone fractures in small animals. A fellow of the National Academy of Veterinary Science and the Indian Society for Veterinary Surgery, he has mentored 38 postgraduate students, published 155 articles, and received 43 prestigious awards for his impactful clinical research. A sought-after speaker at international and national continuing education programs. Dr. Adarsh Kumar, a visionary leader, clinician, and educator, dedicated to elevating veterinary care through innovation, education, and excellence. These are few words about Dr. Adarsh Kumar, a young, dynamic, and passionate veterinarian. Thank you very much, sir, for sparing your time, your valuable time for us.
Thank you, Dr. Vishal. So, shall I start now?
Sure, sir. Sure.
Okay, I'll share my screen. Am I audible, Dr. Vishal?
Sir, you are audible. Yes, you are audible and screen is full size.
All right. Okay. So, thank you, Dr. Vishal and Oriheal Life Sciences for having invited me here. A lot have been said by Dr. Vishal about me. And just I want to tell all the participants who are figuring out in this webinar is that I'm not a big shot. I'm still a student of veterinary sciences. So one of my area of expertise is the dentistry, veterinary dentistry. So without wasting any time, I'll go ahead. So I'm going to divide this webinar schedule as requested by Dr. Vishal. Will compose of 4 lectures, and the webinar 1 will be about the fundamentals of the diagnostic techniques in orodental care, which is going to happen today. And then afterwards, number 2 is a surgical techniques for managing common orodental disorders in companion animals. Number 3 would be the tooth extractions, especially the exodontics in small animals, indications, instrumentations, and step-by-step procedures. And finally, we'll end up with some of the advanced dentistry, that is the endodontic instrumentation and materials, and something about the crowns which we have developed here. So today's topic is the fundamentals of diagnostic techniques in orodental care. I'll talk about very basics in this. Let's not skip the basics, the instrumentation, some of the clinical considerations and practical tips for managing the oral disorders. Okay, now a big question: why do animals use their teeth for? Well, for us, our smile matters, but for them,
for capture of prey, chewing, and like eating purpose.
yeah. Okay, so chewing is one, and then catching prey, and the self-defense. So 3 very important functions are there. But always remember that when it comes to self-defense, chewing and catching prey, an animal or your pet deserves a perfect bite. He's not entitled to bite you, but he deserves a perfect bite. So perfect bite leads to a perfect health of your pet, of your companion animal. Okay. Now, what do veterinarians see when it comes to the orodontal pathology? Now, as you all know that this leads to the fear, anxiety, stress, pain, and suffering in the companion animals. It affects the overall health. Of course, the longevity is affected. Quality of life becomes very poor when there is orodontal pathology. Then interaction with its owner without exhibiting obvious clinical signs of disease is also, the playful nature is also gone. So that is one thing which is very, very important. And the other thing is once the orodontal pathology sets in, the animal starts looking like a very older animal. Now, you have 3 types of skulls. Mainly the dolichocephalics, like the Dachshund is there, then macetocephalic, right? Or Labrador is there. Then you have brachycephalics, like, Pug, the Shih Tzus are there. So type of skull, whenever you're doing a charting, mentioning type of skull is very, very important. You do the clinical examination of oral cavity in 2 ways. One is the conscious oral examination. Look at here. Now, this animal, here we are doing a conscious oral examination. Not much of the oral details would be visualized in the unconscious oral examination, but it definitely gives a lead to the veterinarian to search for the further pathologies. And then the conscious. I think it has been different here. So this is unconscious animal. The animal is under the anesthesia, and then whole of the mouth cavity is being explored. And this is the mouth gag, which is very, very typical in the orodental procedures. Now, if you see the oral cavity from the lateral side here, okay, just remember this space here. This is known as the diastema. So this diastema is devoid of the tooth, okay, and it's a space where your finger can be inserted. So you can insert your finger inside without the fear of being bitten by the animal, and you can just open the mouth here. So look at this, jugal mucosa. Now jugal mucosa is very loose. Alveolar mucosa is tight. Gingival mucosa is very, very tight. Why jugal mucosa is very, very, what do you call, loose? And their lip commissure is very big. Why? Because they are meant to catch the prey, catch the loaf of the meat, and they can go somewhere, sit, and can easily eat. That's why the commissures are big. The jugal mucosa is, it is loose to hold the, the loaf of the meat or the prey in the mouth. Okay, so in this picture, you are seeing the diastema, which is very, very important, alveolar mucosa, which is very, very important here. Some of the lip fold, which goes and inserts behind the canine teeth. Okay, I will further develop it now. This is the way how you catch hold. So see here the finger, the thumb and the finger in the diastema. So once you open up the mouth of a friendly dog, you can easily open it up. Just don't just try to, open it up like, applying a force, don't. So the only thing is when you open the mouth of the animal, set aside your ego, you'll always be the loser. So easily and handleably, if the animal is tractable, you can easily open the mouth and can have a lead of this, but rest of the examination or detailed examination is being done only and only when the animal is being anesthetized. Now look at a certain closer picture here. So let us say this is a tooth here, okay, and it's a molar. So you have the alveolar mucosa, okay, then you have this gingiva here, gum. So this line which differentiates the alveolar mucosa and the gingiva is called as mucogingival junction. And the gum or gingiva which is casing the tooth is called as a free gingiva. Okay, remember this. How about these? Now, this is the oral cavity of adult dog, 42 teeth. Like you can see the pincers here, very sharp teeth, very sharp edge teeth. So this is the oral cavity of puppy. So here the deciduous teeth are there. Now just look at the maxilla and the mandible here. So this is the maxilla here. So you can see the incisors like this, the canine here, the premolars and the molars here. And when you flip it on the lateral side, when you see from the lateral side, you see the side incisors. This is canine and this is the diastema. 1, 2, 3, 4 are the premolars and then the molars. You see the mandible. Mandible again, you have the incisors here, right? Then the mandibular canines, the premolars and the molars. From the side, now this is the mental foramen here. Okay, so this again becomes important when you see or when you go for the mental nerve block. So this is the canine here, and these are the premolars and the molars. And just to give you idea or recap of the anatomy, which you might have studied, and I think most of you may be knowing, it's just a recap. So then comes a tooth numbering in dog, which is very, very important, So in the modern veterinary dentistry, we don't write the, the incisors or the canines or the premolars or the molars. We always give a Triadian system number to the jaw. So what happens is that we divide the upper jaw into two halves, 1 and 2, okay, and the lower jaw into 3 and 4. So on the right side, The teeth are 101, 102, 103. Look at here. Look at here. It is divided here 101, 102, 103, 104. On the right side of the upper jaw. On the left side of the upper jaw, we go for numbering 201, 203, 204. Okay. So if you go by the downside, again, the mandibular the jaw is also divided into two quadrants, the left and the right. So the number on the left side are the 4, and on the right side, right side is a 4, and the left side is a 3. Now this Stridian system is a perfect system to delineate, to isolate the tooth in question. Molars are on the upper jaws as well as the lower jaw. But when you mention that tooth number 309 is a tooth which has a questionable viability, so that becomes a paka, that becomes, it becomes understood that, it is the ninth tooth on the lower jaw which is affected. So make a practice of marking or charting the tooth as per its number, which has been allotted according to the Freudian system. Okay, just we have replicated here. See, so what you can do is you can always place wherever your OPD is there, wherever your OT is there, or you're examining, we are placing, we have placed this chart, and accordingly we see the chart, and from the chart we chart the tooth which is having a questionable viability, and eventually what happens that you come to know that now this is 307 or this is 107 or 207. So this is again one thing which you always be keeping in mind. Okay, now this is a chart. Now this is a chart which has been, this is electronic veterinary dental scoring here. So whenever you do a dental scoring, this chart is very, very important. Somewhere the software is available, but if you don't have the software, you can have a printout of this, a bigger printout of this. You can put a name, date, client, patient name, and then accordingly you can examine 101, 102, any, for example, if fracture is there, FX. So you can tick over here, 104 is, so whatever affection is there, you can easily mention in this. You can have the journal notes and the notes here. Okay. On the side, you have these lesions. So M is for the missing tooth, P is for the persistent deciduous teeth, FX is for the fracture. So this is for reference here. So always a good idea when you do a planning, a dental charting is very, very important, right? Then you can give a account or a note on the occlusion. Occlusion is the occlusal relationship of the upper and the lower jaw. So there are a lot of malocclusions, congenital malocclusions are there, which can also be noted out. Then the calculus level and the oral masses. So you can easily mention Epuris on the root of, let's say, 107 or 207. So you can write this, and calculus level we will develop further as our talk will progress. Now, feline cavity is also the same. Here also we divide the tooth according to the Trident system. Now, when you talk of the felines here, you have deciduous teeth, which are 26, and the permanent teeth, which are 30. So in dogs, you have 42 teeth. Okay. Now, here also, you will divide the jaw in cats into two halves, right? Right, left, and that same numbering is there as we have discussed earlier for the dogs. Okay, so same thing. Okay. Now, very important. This poster is very, very important here. Okay. So you have one root tooth, which is having a single root here. Okay. Then you have the premolars here. These premolars have two roots, right? Then this three roots, the molars, right? So it looks like this. The three roots are like this. So why they are important? They become important when you go for the exodontics. That means the extraction of the tooth. You just cannot pull out the tooth from there. Sometimes you have to make a flap. When you're making a flap, you have to divide the roots. That we will discuss in our different. Likewise, it is true for the lower jaw also. And this is for the felines. So now this is a perfect Caesar bite here. So teeth, they should come. They should have the occlusal relationship like this. Okay. Now the front tooth, they should come like this. There is an occlusion relationship. It is like this. Okay. So these teeth, they should meet like this. Any deviation from the Caesar bite will tell you about the malocclusions. Okay. Now the structure of the tooth here. So if we divide this from here, now this one is a crown here. The tooth which is below the gum line is a root here. Okay. And the tooth has a structure which is outside, which is visible to you, is the enamel. So enamel is a portion which is only there in the crown. Then comes a second layer, which is dentine, very hard. It grows up to the root here. Now this dentine is creating a gap within, which is known as the pulp cavity, and this pulp cavity harbors the nerves, vessels, veins, and the arteries here. Okay, so crown and the root here. Now this tooth is, it is fitted in the alveolar socket. So this is the alveolar bone. Now the ligament which is responsible for a very strong relationship of the tooth with the alveolar bone is known as periodontal ligament, right? And periodontal ligament, which is attached to the cementum. Now this is a part which cements the dentine in the alveolar socket. Okay. Just see here, if any kind of fracture is there and the crown of the tooth, either by caries or by attrition or by fracture, is exposed, it exposes the pulp cavity. So it becomes highly, highly painful. And in that case, we go for the oral restorative procedures, or we go for the RCTs, or sometime we choose for the extraction if the periodontal ligament relationship is gone. Same. Now the periodontal tissue, what we talk of the periodontium. Periodontium is a tissue that holds the tooth in the mouth. So it is composed of the alveolar bone, right? Periodontal ligament here, the gingiva here, supporting connective tissue, and the vessels. So tooth is not a tooth is tooth, but the supporting structures of the tooth which hold the tooth is known as the periodontium, right? And most of the diseases in companion animals is of the periodontal nature. right? When I talk of the periodontal diseases, that means the alveolar bone, periodontal ligament, gingiva, and this supporting tissue is affected. Now, you have to divide your examination into 4 stages, right? One, always very important, is gaining a thorough medical and the dental history. So you have to ask about a medical history or the dental history which the patient has faced earlier. Okay. Then you go for the extraoral physical examination to visualize and palpate the head and neck region in the awake patients. Now, what you do is you do not do the intraoral examination. You do the extraoral examination. Try to compress the, the mandibular jaw, come over the incisors here, and you go back up to the maxillary tooth and up to the TMJ. If any teeth is in question, your deep digital palpation will make the animal to flinch the head, flinch the limb, or react. So that gives you indication that there is something wrong in the tooth, which can further be explored. Then the intraoral examination in awake patient, as I told you earlier, you try to open the mouth. If it is easy, the patient is tractable, the patient is cooperative, you can go for the intraoral examination. Otherwise, you can always fix up the the intraoral examination, which has to be done under the general anesthesia, right? But remember that in general anesthesia, the findings you might see during the extraoral examination would not be visible, will not be felt, because under the general anesthesia, the animal won't show pain, but you can see the mobility of the tooth, right? You can take the x-rays, right? You can see the extent of the gingival recession. I'll develop it further. You have this periodontal pack. So before going for any kind of examination, you should have this periodontal pack ready, right? These include those instruments which are responsible, which we can do a dental cleaning and we can do a dental charting, right? So you have the explorer with the periodontal probe, you have calculus removal forceps, scaler, and the curate. Now this is the explorer here. So this explorer is used to detect the plaque and the calculus, and it is also used to explore the caries with just you have to curate the area and you can see any kind of attrition, you can see any kind of the loss in the animal. Okay, so this explorer also functions by gliding on the tooth surface in search of the irregularities. So you always see the regularity of the tooth also, some pitting is there or not, right? So shepherd hook is the most common explorer in there. This is known as a shepherd hook. Then the periodontal probe here. Now look at this. The periodontal probe should be held in a pencil position here, right? It has the marking 1, 2, 3, right? The 4 is missing, 5, 6 is missing, 7, 8, 9, 10. Okay. Now periodontal probes, they are used to determine the gingival pocket depth. I'll show you in the next slides how it is to be seen. Okay, so we skip it. There is a normal also. So up to 3, the banded probe represent a normal length, but if we go beyond 5 and we go beyond 7, the pocket depth increases. That means that gingiva has loosened, and it is losing its attachment to the tooth here. So always hold the periodontal probe like you are holding a pencil. Now, this is a William periodontal probe. You have the dental mirrors. You can see on the other side of and this is again a dental explorer. So this is how you do the pocketing here. Insert this William periodontal probe into this gingival pocket here. Measure the pocket depth, right? Up to 3 to 5 mm, it is normal. If we go beyond 5 mm, then it becomes abnormal, right? Now this is a dental mirror. You can keep a dental mirror. So since you can see the labial surface, you cannot see the lingual surface here. So you can keep this on the side and you can easily see the lingual surface. Now this is again probe around the periodontal pocket. Can you see here very easily this probe is going inside. So this is normal here. Okay. But then always consider, can you see this growth here? It's a big growth here, right? So this is a growth of the gingival hyperplasia. Now, if you insert your periodontal probe inside, we call it as a pseudo-pocketing. Now, it is not a pocket which is created between the gingiva and the tooth. No, it is not. Since it is a hyperplastic tissue, so this is known as pseudo-pocketing. So never mention a pocket depth. It has gone up to 8 or 9, right? So this is a pseudo pocket. But if it goes beyond 5, reaches 7, that means it is very, very abnormal. Then the furcation. So furcation is like this notch here. Okay, this is a notch here. This is known as furcation here. Okay, so when you pass your periodontal probe from here and it crosses the other side, see here the X-ray very much so. This is a furcation angle. This is a furcation angle. Normally should not be visible. If it is visible, that means there is a gingival recession, right? The gingiva or gum has recessed. It has gone back. It has been pushed back because of the presence of calculus or any pathology, and this furcation is exposed. So once the furcation is exposed, you have to act accordingly. I'll tell you how. So if the probe goes into furcation up to 1/3 of the crown width, we call it as grade 1. If it goes up to 2/3, we call it as grade 2. Now, if goes through and through the furcation, we call it as grade 3, right? From the labial to the lingual side, we call it as F3. So here it is F3. See, this is F3. Whole of it is going inside. Then you may have to go for once you find the furcation, you may have to go for the dental radiography. So this is a dental radiography machine here. So you can go for the dental radiography. You can use a conventional one also. I'm using this. This is a handheld machine, dental X-ray machine. It has this RBG sensor. You expose with the RBG sensor and you can get the resultant image over here. Now the question which is pertinent to be asked here is that what size is to be used. So normally if you buy a human machine, they have sensor 1 and 2. So normally you go for the sensor 2 here, which is larger in size. But IM3 has come up with a sensor number 5 also. This is a CR plate here. Okay, so look at here. So you can see a smaller one. Size 2 will give this much of an area, but if you're taking a bigger size, you can expose a bigger area over here. So that is the advantage of having a bigger sensor. So how the sensor is to be used, just look at this video. So you take this plastic wrap, okay, and this is a sensor, which is a number 2 sensor, which we are using here. Okay, then you cut it, put it inside. You should not actually directly put it inside. So protect it with the help of a plastic, and then you can put a wet wrap over it. This is a sensor now ready to be inserted in the oral cavity for exposing the tooth. Okay, and without being getting damaged by the tooth or the fluid of the tooth inside. So this is ready. So you can put it inside the tooth here. Okay. Now see how you expose it. So animal is anesthetized, the sensor goes inside, and this is a machine which is a fixed machine here with a stand, so you can easily expose. So this is a vet specific software. So whatever tooth you can click and you can get the resultant image. So normally he's our student, Dr. Sudhir Alowalia. He's taking the X-rays here now, full mouth in 3.5 4 minutes. Just look at this video. It's very inspiring video. So again, leave it. So Yeah, fix it like this so that you can have a full mouth X-ray. Click it. Okay. Now change towards the other side, the left side. The incisors are being exposed. So you're deriving the images. The software is storing the images. Later you can have the overview and the preview of all the tooth, and you can compare the tooth pathology. Okay. So the caudal tooth. So those who are starting the dentistry, it is very, very important to understand that, should now take out the, do not always overturn the animal with this tube here. You will end up getting the trachea being ruptured, because if you are moving without disconnecting the inhalant corrugated tube, it can result into a tracheal rupture. Now this is for the lower tooth. This is how we are exposing the lower tooth here. So the catch point here is always and always try to and read it about the X-rays, to fix a central beam in the area of the interest. And there is an angulation also. So X-ray or taking X-ray is entirely, is a different subject. Will can cover one of the another webinar also. But I'm just giving you the overview how the X-ray are to be taken, and it is always and always good idea to go for the full mouth X-ray once. Expose whole of the mouth, and then you can make the animal to come into the position, and in the meantime you can survey the tooth cavity and can act accordingly. Okay, so this is another exposure here. So that's the exposure. See the angles here. You should study the angles. Okay, so done. In 4 minutes, whole of the mouth X-ray is being completed. Okay. Now there is another device which is known as DentaCam, or the oral oral camera. So you can insert the camera inside, and you can see on the screen the tooth. You can see the magnified image of the gingiva and the tissue here. Okay. Likewise here also. So all of the tooth you can easily watch, and you can serve. Now, why dental cam is very, very important? Why dental cam is very important for the client communication, I tell you. Okay, so you can always communicate with the client based upon these videos and the x-rays to tell about the oral pathology, so that they get convinced. Otherwise, it is very difficult for the owner to tell that what kind of pathology or oral pathology is there inside. I think you're getting my point. So you take a standard X-ray here. For example, this is a normal looking oral cavity. This is a normal looking, perfectly normal looking oral cavity with no tooth problem, no gingiva, there is no periodontal disease, but it is giving, the X-ray is giving you indication something like over here, but the exact pathology could not be delineated in a standard X-ray. But when you go for the dental X-ray, you can find an impacted tooth here or the retained tooth here. So that is the beauty of the dental X-ray of taking, which enables you to take the X-ray of a particular region, and you can see the periodontal ligament also and the associated tissue around. So this is again an X-ray. Here you find there is absence of teeth here, right? But when you expose the X-ray, you find such kind of embedded. So these can be extracted out. And in felines, if resorptive lesions are there, so X-ray is another technique, which gives you the idea about the resorptions. Now I'll just go here. See, now this is a jaw, a lower jaw, a mandibular canal here, right? Now this is a tooth here. Outermost part is known as the enamel. Below the enamel is a dentine. Dentine is harboring, it is having a three roots here. Dentine is harboring a pulp cavity. Okay, so the assessment of pulp cavity is there by with the X-ray. Then you can find this radiolucent line here. This is a radiolucent line here, which is moving on the root, and it is almost going up to the gingival line. Okay, this structure is known as the periodontal ligament. So when periodontal ligament is shredded, it is not visible, it is discontinuous. It gives you an idea that the tooth is losing its attachment to the alveolar socket. So in that case, the tooth will become mobile, and mobile tooth, you can always opt for the extraction. So this is the alveolar bone here. Can you see these X-rays here? Can you find this is a tooth here? This is a tooth here. You find a resorptive lesion here. You find a resorptive lesions here. Okay. So here also the resorptive lesions. Okay. So here you cannot see you don't see the periodontal ligaments here. So again, tooth resorption is there, right? So likewise, you can have the idea. Again, periodontal ligament is not visible here. Okay. Now, intraoral radiographs, they assist in the assessment of the periodontitis and provide information regarding the alveolar bone loss, right? So it takes roughly around 30 to 50% mineral loss of bone structure. So before radiographic changes on the dental radiograph can be detected. So just imagine that until and unless 50% of the mineral loss of bone is not there, the radiographic changes do not appear. But once they appear, it can be the horizontal bone loss or the vertical bone loss. Look at here. Now this is a horizontal bone loss here. Okay, so second and third premolars, they are showing the furcation which is exposed here. See, such a big hole here. This furcation angle is totally exposed, and you know, if we see the gum here, there is a recession, it has gone back. So when you take the X-ray, so normal line should be like this, you know, the normal line, a gingival line should be here. Okay, so this much of the area is exposed, so that is a horizontal bone loss which is being indicated in the X-rays. So when you open it up, please do not open the mouth, you know, beyond the desirable, you know, opening. If you open up to this an extent, the animal will feel blind for some time because of the pressure on the facial nerve. So this opening of the mouth exerts effect, you know, the pressure on the facial nerve, and for certain period of, the trigeminal nerve, and for certain time you find there is a blindness. Okay, now open it like this. Very comfortable position here. So see how wide the mouth is being opened. So avoid this. So you scored the gingivitis grade 1, grade 2, and grade 3, grade 4. I'll show you here. Okay. Can you see this is grade 1 here. So grade 1 mein, you can find that there is a perfect color of the tooth. There is no bone loss. The gingiva is not bleeding. So when you find a grade 1, if you touch it with the probe, periodontal probe here, it will start bleeding. Okay. So those who are brushing your own teeth, if you find a streak of the blood, that means you have grade 1 periodontal disease. Okay. So little bit of a congestion is there here, and this congestion is responsible for producing a grade 1 gingivitis or grade 1 PD. Now, along with the grade 1, you find a swollen gums here. The gums, they are swollen. There is infection around tooth here, and some shallow pockets are there. This is grade 2. Okay. Then you see here little bit of a bone loss, and you see whole of the gums, they are swollen. The color has changed here. The, you know, the pockets become shallow, and if you try to, you know, see the mobility of the tooth, some of them may be mobile. So this is grade 3 here. Okay. Grade 4. So grade 4, you hardly find a good color of the, this is highly congested, it is bleeding, you know, it is hyperplastic, it is showing a granulomatous reaction here. No occlusal surface is properly visible, furcations, they are exposed, and look at the color as well as bad odor of the mouth. So this is grade 4. So you grade accordingly, right? So you can always chart that this is grade 1 or grade 4 periodontitis. So look at here. So red gums and the swollen gums. So this is red gums. The moment you touch it with the periodontal probe, it will start bleeding. So this is stage 1 periodontal disease. Okay. Now here, infection around the tooth. You can see the infection around the tooth. And when you take X-ray, you find the shallow pockets here. These are the shallow pockets. Stage 3 and 4, you can see the deep pockets here. See, whole furcation is exposed, highly mobile tooth, tooth is loose, and you find that there is a alveolar bone loss. So that is stage 3 and 4 periodontal disease. Now, when the calculus comes to you, I'll deal with the calculus when I will deal with the scaling. So this is the erythrocin dye here. So what we do is that we apply the dye on the tooth, the gums here, whole of the tooth. Then we keep it for 3 to 5 minutes, and then we wash it. So once we wash it, this dye reacts with the calculus and it will delineate the area in the pink color. Now, as a veterinary dentist, dentist specialist, you have to clear this pink color area. This pink color area has to be cleaned. That means these are the sites which are discolored or giving a pink color and having a deposition of the calculus or the tartar. So once you clean the tooth, take care that all the pink color should be removed. Okay, but be very gentle. So see, this is how the teeth used to look like. It is we are scoring the plaque and the calculus here. So it is applied on the labial as well as the lingual aspect on the internal side also. Then we wash it with the water, right? And you can see these pink areas. These pink areas. Okay. So whole of these areas are, because you can see the calculus by naked eye, but there are certain areas on the tooth which cannot be seen by the naked eye. So what do you call, you try to reveal those areas which are concealed here. Okay, now this is the supragingival calculus. This one is the supragingival calculus, and the calculus which is below the gingiva. Sorry, which is below the gingiva is the subgingival calculus. Now, the problem with subgingival calculus is that with the passage of time and the calcification, it becomes so hard, almost like the structure of the tooth, and it is pushing the gingiva back, and making the gingiva to recess like anything and exposing the furcation angle. So that means that eventually, if it is not cleaned on time, the mobility will start and animal will finally lose the tooth. Okay. See here, I'll just give you example here. Can you see this here? This is the gingival recession here because of the calculus. Now here should be the gum line, but gum line has receded back. Look at here. Look at here. This calculus has forced the gum to go back. Okay, that's why the cleaning becomes very, very important. Now here is a pocket depth. This is 1 to 3 mm, almost like a normal. This is 3 to 5 mm. So it can be revealed because this is give you. So one reading is 1 mm, 2 is 2 mm, 3 is 3 mm, 5 is 5 mm, 6 is 6 mm. So here you can see all of the periodontal probe has gone into the gingiva. That means the periodontal pocket depth is more than 5 mm. See. So how we are, touching and seeing it. So this is grade 1 furcation exposure in 207, right? Sorry, this is grade 3 and this is grade 2. So I'll go back here. This is grade 3. This is going back through and through from the labial to the lingual. Okay. So we call it as a furcation. Now to tooth mobility. See, you have to see a tooth mobility, the vertical and the horizontal mobility. So when there is grade 0, that means no mobility. Grade 1 is the horizontal movement, sidewise movement up to 1 mm. Okay. Grade 2 is the horizontal movement more than 1 mm. And when the teeth is moving both sides, the horizontally also and the vertically also, that means it is grade 3 and it indicates that it has to be extracted out. See the mobility again. This is the horizontal movement we are seeing, a vertical movement we are seeing. Okay. Now, see, this is the grade 1 motility. Okay. So this is grade 2 mobility. And this is the both towards the horizontal and the vertical. This is grade 3 mobility. Okay. Now you find the dental attrition here. Can you see a good canine teeth here? Here you can see that whole of the pulp is exposed. These are the incisors. This is the dental attrition. Such animals are presented with the history of biting a fixed object, ball, garden pebbles, etc., etc. Look at, see, all the dental structures, almost the crown has been lost. Here also the crown has been lost. So when you find certain conditions, we call them dental attrition here. Look at the canines here. Look at the canines here. The pulp is exposed and half of only canine is there. Rest of the all has been there has been the attrition here. See. So can you see this here? The pulp is exposed. We call it as a pulpitis. Pulpitis because of the tooth attrition. Look at this canine and look at this canine. This pulp is exposed here, right? The pulp canal is exposed. So this is pink discoloration. When you see with a torch on the other side and you see the light, you will see that, whole of the tooth structure is visible. So this is a pulpitis showing a pink discoloration. Now, very important is the regional dental nerve blocks when you examine the animal or when you do some of the interventions. So what I use is the lignocaine and the bupivacaine. You can mix them or you can use only bupivacaine. My personal choice is I use bupivacaine alone. Okay, so the dose is 5 milligram per kg and bupivacaine is 2 milligram per kg. Largely speaking, 0.5 ml in large dogs on one side and 0.3 in the small dogs, right? 0.1 to 0.3 in cats. Okay, so now you have rostral maxillary, caudal maxillary, rostral mandibular, and the caudal mandibular blocks, right? But remember here you require the syringe which is 25 to 27 gauge. Okay, not lesser than that, because you are going into the foramen. So if the bigger gauge is there, it can injure the structures inside. It cannot even go inside sometime in the cats, especially. These are the nerves of the skull. Just a reference picture to show you how these nerves, they are exiting. This is the infraorbital foramen. This is the mental foramen. Okay, so see here. Now, for the dental nerve blocks, the first one is the rostral maxillary infraorbital nerve blocks. So we call it as infraorbital nerve block or rostral maxillary. So it is inserted. You palpate deeply inside, feel the neurovascular bundle, right? And then you insert your needle inside, right? It is going inside here, and then you inject 0.3 ml of the bupivacaine inside. Okay, so this much of the area is being desensitized when you are using the infraorbital nerve block. Very good nerve blocks. You can, whenever you start the procedure, you start it by first of all, cleanse the mouth with the chlorhexidine wash, and then you first go for the desensitization, because long effect, 6 to 7 hours of the effect is there. So post-operative pain is also being alleviated. So there is a preemptive analgesia. That is the caudal maxillary nerve block here on the back. So see here how we are using the caudal maxillary nerve block. If we twist it, just to show you, here you have to deposit the local anesthetic here, and this much of area is desensitized. So here also, this is the rostral mandibular here. This is called as mental nerve block. So when you press it, you will find a depression, insert your needle inside and deposit. So this is the area which can be desensitized by blocking the nerves on the mental foramen. And that's the caudal mandibular nerve block. You make a straight line on the jaw here, angle of the jaw, right? From the inside, you have to go inside. From here, you have to go inside, right? I would love to show you live, but we still have to devise that mechanism actually, and Vishal has to take a lead in that. So for the felines also, this is again the infraorbital nerve block. Here is the infraorbital foramen. This is the mental nerve block, the mental, okay? And that's the caudal mandibular. So you're going back from the inside of the lower jaw, from the angle of the mandible, and depositing the. So this gives a fair amount of the analgesia, and you can work on the procedures which are even very, very invasive. So infusion volume, I told you that if patient is weighing less than 2.1, 2 to 6.1, 0.25, and more than 6.25 to 0.3, right? Large dogs are there. You can even go up to 0.5. Now I'll come to the dental calculus, dental scaling and the polishing. I've given you overview, although many things are there, but I just want to make the things simpler for you. Okay, so when you talk of the dental calculus, I told you that periodontal tissue is composed of the alveolar bone, periodontal ligament, gingiva, supporting connective tissue, and the blood vessels. Okay, now what causes the periodontal disease? remember that 85% of the incidence rate is there in the animals. Those are over 5 to 6 years of age. Okay. So bacteria forms plaque on the teeth. Okay. Here they'll form the plaque on the teeth. Plaque finally hardens. It is calcified. It will form calculus. Right. So plaque starts to touch the gums here. Right. So then here the periodontal film is being made. Under the periodontal film, the bacteria thrives, survives. So it will start releasing the destructive chemicals, lysozymes and the enzymes, and will also threaten the immune system of the patient. Finally, at this stage, it will start destroying the attachment of the gingiva or the gum to the tooth, leading to the gingival recession, which I showed you earlier. Simple is the physiopathology of the pathophysiology of the periodontal film. Okay. Then if you talk of the dental tartar, so dental tartar is a generalized term. Okay, it is generalized term, but scientifically you'll always be telling that it is the calculus. So first there is a deposition of the plaque when it is being calcified or it is mineralized by the concretions of the salivary calcium and the phosphorus salt, it becomes a calculus. So this calculus contains oral bacteria, bacterial polysaccharides, mold, salivary proteins, food debris, and cellular debris, right? So what happens is that mucin separates from the saliva and it is a sticky fluid. The saliva becomes sticky and it combines with all certain things. And you will always find that the mouth of the patient who are having a severe periodontal disease, you'll find the saliva drooling, sticking to the hairs around. An animal is in a very bad condition with a very foul odor. That gives you an indication of the periodontal disease. Now, this is a normal animal. The things, they start with the plaque. Okay, plaque is the deposition of the organic material on the tooth. Now, when you have a plaque, it can be removed by the brush. But once it is mineralized, it is calcified, it cannot be removed by a brush. It can only be removed by the ultrasonic machine or the hand, what do you call the scalers. Okay, so that's the difference between the plaque and the calculus. Initially, it is a plaque, but then it is converted to calculus once it is being mineralized and it contains bacteria and all kind of the cellular debris. So you need to have such kind of a dental workstation. You have this panel here. So that is the scaler here, right? Then you have a low speed handrail. You have this polisher here, and you have this air water syringe. You can control the flow of the water and air from here. Okay, dental surgical loops. You can mount the dental surgical loops here, which magnifies the tooth, and you can see small little structures. Even if you just see the difference, you do a scaling by naked eye, and then you put on these dental loops, and you will say that you've done half of its job. You still have to clear much of the teeth. That's why in the areas in the tooth having a larger surface, always try the surgical loops if you have. Now, types of scaling tips are there. This is a flat beaver tail. So you can go supragingival. This is a rounded narrow tip which doesn't injure, so you can go subgingival under the gingiva to clean the calculus. This is must. So this is a pharyngeal pack. The one you get this material which is being used in kitchen for soaking the water near your wash basins. So you can cut it and you can tie it with the old drip set, and you can always insert or you intubate the animal. Once the ET is being placed, you put it inside, right? This will block the passage here. So you will avoid the water and the injections and the air as well as the calculus to enter into the stomach or even into the trachea. Okay, so this pharyngeal pack is must. You have to put it inside. You have to stuff it like this. This is the ET here. What is the mechanism of action? So it has ultrasonic vibrations, it vibrates, and it with the high frequencies, and it breaks down the tartar, it dislodges the tartar from here, right? So this is a gum line which is being cleaned. The second effect of the ultrasonic scaler is that cavitation effect. Okay, what happens in the cavitation effect? The waves, they create the tiny bubbles, and with the cooling water, which implodes, and it helps disrupt the periodontal film, which we normally call it as a biofilm here. Okay, so just see here how this biofilm, how this, bubbles, tiny bubbles, they are, eroding the biofilm which is being made on the tooth here. Okay. So we should be very, very clear about what is the mechanism of action of the ultrasonic scalers. Now, this is the scoring which has been done. I told you earlier also. This is the periodontal probing we are doing, and we charted the animal. So this is the manual scaling. So we are using a calculus removal forceps here. So what I always suggest is that you should not always depend upon the ultrasonic scaler on the hand scaler. If the tooth is having a lot of deposition, like the one this tooth is having a huge deposit, almost 5 to 6 times thicker than the tooth, break it with the dental calculus forceps. Once you break it, take it out, whatever remains there has to be removed by the hand scaler and finally by the ultrasonic scaler, because what happens is that you cannot afford to have a lot of heat being or tooth being subjected to the heat produced by the ultrasonic scaler. Ultimately the heat is being produced, so try to avoid the tooth being thermally damaged. Okay, so you go for the brushing. Then I'll tell you how to do. This is the brushing. Okay, and then you can go for the trophy basting, and this is the polishing off. So polishing is done to clean, to clean the tooth here. I'll now in detail, I will show you how it has to be done. Okay, so can you see this? This is before scaling and this is after scaling. Okay, so here also before scaling and after scaling. So this is before scaling. Look at the furcation exposures, how clean the teeth has become. So I told you about the heavy calculus. Now this is a calculus breaking forceps here, or cracking forceps. You apply it here, and then the tenacious calculus, it requires to just give a clip here like this, give a clamp over here. So with the multiple attempts, you end up how hard it is. Now you've broken it into the pieces. So that has eased out your work. Actually, you are saving the teeth from excess of the application of the dental ultrasonic scaler here. Okay, so again, the same tips which I've told you. So flat beaver and the gingival scaling here. Now what happens is that, and they are very noisy actually. The ultrasonic scalers are very noisy. So now in the market, you have the silent ultrasonic scalers here, very low noise. So that won't scare the dog. And then some of the scalers have these adjustments, so these presets. So 5-gear cleaning, we normally call it as. So you can switch on the soft, you can switch on the comfort, so you can switch on the standard, then the strong, and then the super strong. Okay, so no need to fiddle with the knob of increasing the frequency. So you can simply choose these presets and you can start doing your job. Plus it has a battery indication also. Now, for the scaling, use only the side of the tip. Please do not use the tip which is on to touch the tooth with the tip, right? Tip is highly, highly damaging. Always use the side of the tip. It is the most effective and least damaging area of the instrument to be placed on the teeth. Okay. Then scale for less than 15 seconds per tooth, right? It is possible to kill the tooth with ultrasonic trauma. Okay. Now, if an individual tooth is going to take longer time, You can go to the other tooth and then come back after 1 or 2 minutes, but do not take more than 15 to 20 seconds on the tooth with an application there, because it will start producing heat. If it is taking time, switch on to other tooth and then come back. Okay. Light touch is actually more effective rather than, poking it with the scaler. Do not give a lot of pressure. Now it will decrease the effectiveness of the scaler. It is vibrating. So it is vibrating at a light touch. Remember that. Be gentle. Gingival tissues are very delicate. It will start bleeding. Then take care. Under the gum line, you need special subgingival periodontal tips, which I told you earlier. Don't enter into the subgingival areas with a supragingival beaver tip. Okay, use a specific tip. Now, in general, the higher frequencies are quieter and provide smaller excursions of the tip, right? So water spray is very, very essential. It has a flushing and a cooling effect, right? So you can always adjust the halo of the water. Itna bhi, don't go for a lot of water. Otherwise, all of the mouth cavity is being filled. Okay. And one point I always tell you, when you change the side, please let the skull be on the lower side. Whatever has accumulated inside the oral cavity should drool down. You clean it. Don't turn on the other side. It will lead to a aspiration of the fluids which are accumulated in the oral cavity. Okay. Then remember that you are breaking a periodontal film which is heavily laden with the bacteria and the other tissues. You should double mask yourself. Otherwise, you will end up inhaling the aerosols. Okay. Now there's a caution regarding the tips and the stacks. As the tip wears, the power decreases. Okay. So 6 to 9 months in the practice, performing 5 dental cleaning procedures in a week, you should replace the tip. Okay. 6 to 9 months in practice and you are performing 5 dental cleaning procedures in a week, you should replace the tip within 6 to 9 months. Now, this is how the ultrasonic scalers are to be held, right? And remember, they vibrate at 45,000 hertz, 25 to 40,000 hertz. So do not apply the tip. Always apply the side to the tooth here. Now, this is a pattern which is a cross-hatching pattern. So how the scaling has to be done, you move like this on the tooth, on the surface of the tooth like this. Okay. And then you move like this. We call it as a cross-hatching pattern. So once you follow the cross-hatching pattern, you end up doing a good cleaning job on the teeth. So just a recap of the sequence here. See, the side is being applied. And one more thing is there. Do not switch on the tip of the scaler outside and bring it on the tooth. Touch the tooth and then switch on. Otherwise, if you're bringing a switched on tip to the tooth, it will lead to the injury. Okay, so look at the halo of the water here and how the teeth is being cleaned. Okay, this is the clean tooth here and this is the gingiva here. So placement of ultrasonic scaler tip against the crown before activation. Do not activate it outside and bring activated tip to the tooth. Attach to, place it on the tooth and then activate it. So this you go for the hand scaling also. Sometime on the very difficult sides, you have to go for the like internal of the canine. You have to use the, you have to use the hand scaler. So clean, it is being rotated like this, this is how you rotate around. The scaler is placed in the pocket, and then a correct angle is achieved. And then you go on the upper side, you can see the arrow, you take it outside. This is the working strokes. So with the very small working strokes, you remove the calculus, and then on the sides, both the sides, right? So once you clean the root of the tooth like this, or you clean the subgingival area, this process is known as root planing in different directions. Then this air water syringe is being used, and this compressed air, when you apply it here, it opens up the area. And when it opens the highly pressurized, it cleanses the debris which is accumulated over here, and it flushes also. So once you created a pocket over here, you've cleaned it. It's doxyrobe gel is there, which contains the doxycycline also. It is 8.5%. So you can always inject perioceutic. So perioceutic means, perio means periodontal, ceutic means therapeutic. So periotherapeutic, perioceutic. So you can always inject this doxyrobe, and place the doxyrobe gel in in the bleeding periodontal pocket. That will take care of the local inflammation and the infection also. Then you go for the tooth polishing. This is the prophy cups which can be attached to the hand pieces, and this is how you do the dental polishing. These are the prophy paste you can apply on the surface of the tooth. So I must show you, maybe having this. Yeah, this is the brushing I already told you, and this is the polishing we are doing here. This is how it is being polished. So polishing is being done to smoothen the surface of the tooth. Otherwise, if you don't do the polishing, you only do the ultrasonic scaling, that means you leave the rough surface on the tooth as such. So that will make the tooth prone to again redeposit the calculus or the tartar. So proper cleaning is must, along with the smoothening or polishing of the tooth using a dental polisher. Finally, you can go for the application of the anti-plaque sealant. So you can apply this gel on the tooth, right? And every 6 months, you can this can be given. So this prevents this application of the gingival dental sealant helps in the prevention of the plaque, and especially should be used in those animals those are very old and having the anesthetic risk, or they fall into a category which is risky from the anesthesia point of view. So that was all from my side regarding my first lecture. I hope I haven't taken a lot of time here. So I will stop sharing here and will be back on the camera here. Okay. Okay, fine. So
Thank you so much, sir.
Yeah, thank you. Thank you so much. Can you see me now?
Yes, Dr. Saab, we can see
Okay.
you now. And I just want to clarify that are you able to see the chat box?
Yeah, just a minute. Yeah, chat box I can see. Views on non-sedated dental scaling options by some vets provides views on non-sedated dental scale. Yeah, see, Well, for the dental scaling, if you go for the sedated animals, yes, you can do it. Yes, you can do it. We normally go. That's why I told you that we have certain scalers which are handheld and battery operated. So you can go for that. But you don't. If you go for the removing the subgingival calculus, it is very difficult. And any procedure which is painful, it becomes very, very difficult. So although we are also doing here where the clients, they are not agreeing for the for the anesthesia, all what we do is we do it. The client have a problem, actually they say that canine saaf hona chahiye. I mean the canine should be okay, then rest of is a problem, but the main problem is on the tooth which are on the back side. Doxyrobe we are importing, sir, and the Doxyrobe is not available in India. But I was discussing with Dr. Vishal about the Doxyrobe. It is a simple preparation. I don't know why we haven't still made it, and I'm very hopeful that once I've discussed with Dr. Vishal,
Sir, we
he'll
have
be making
started.
it.
We have started. Actually, we are already working on some dental paste, dental wash, and dental
Yeah,
gels.
yeah,
So
that's good.
definitely we will include this thing also in our dental range.
So there's a question by Dr. Snehal, everyday dental hygiene for pets. Any tips? Yes, your dental hygiene is very, very important actually. See, the only thing I tell that they should be given some hard toys to chew. Okay. We are relying upon the commercial food, which is sometimes very dry, sometimes it is very wet. So what I always tell is that whenever you go to market and you buy a bone for the animal, for your animal, you take that bone and you hit your knee. You hit your knee like this. If your knee is paining, don't buy it. If your joint is paining, don't buy it. Buy which buy the hard objects or the bones which are gentle on your joints also. Okay, don't go for very hard this thing. Some of the other tips are very important. We always say that every 6 months you go for scaling. If somebody is not coming every 6 months, they can come for the checkup of the deposition of the. They are very hardy animals. Those are having some of the congenital malocclusions. So you do once, and within 3 months there is again a deposition of the animal. And most of the patients which come to us are having a history where the client is feeding the animal by hand when animal is not picking up the food. So hand-fed animals, they are getting more of the problems. Okay, now Jacob says, excellent. Okay, fine. Even though I'm practicing dental scaling since last 15 years, I learned, oh, thank you. Regular paste or mouthwash, rinse. Yes, 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 yes. Yeah. See, do not use the tooth paste which is meant for the human beings. It has a fluoride. What you do, you rinse your mouth and then you swish out. Dogs do not swish. So whatever you give them, whatever you offer them, they will engulf it. So their toothpaste, they contain the enzymes which break down the organic material.
Yes.
Okay. And the smell of the toothpaste should be like food. Okay. Okay. What are some of the worst food items which need to be avoided? I would say biscuits. I would say biscuits or pure like chapatis they are giving. They are not cleaning it. So rotate them, give them fiber, give them something to chew, give them fruits also. Do you recommend extraction of the tooth if gingival recession? Yes, I would say, but I will always take the X-ray. It's a very good question that if PPD is more than 6 mm, should we go for the extraction? Yes, you always keep the option of the extraction open, but before extraction, check the mobility and check the integrity of the periodontal ligament. You can still save the tooth by alveoloplasty if it is not mobile and if the periodontal ligament has some integrity. Do not directly go for the exodontics. Oh, Nikita is also there. Nikita is doing very good dentistry. Can you please make a presentation how we can use normal CR X-ray? Okay, sometime we will do it because it was Dentastics. Yes, it is recommended. I won't say, not recommended. It is recommended. You can use it. But in the dog, what happens is that we give the Dentastics, and some of the dogs, have the habit of eating, like, like is there is no tomorrow. So that is the one thing we should always keeping in mind. So next is Dr. Who is this? Chandrasekhar. Fixed X-ray machine can be utilized where dental X-ray machine. Yes, it can be. Fixed X-ray dental machine. Yes, it can be used. We are using it. But it should only be the dental X-ray machine which is fixed. Okay. Any tips for the same, sir, to achieve best visualization? Sir, you must read the X-ray. I will share the, with the link with Dr. Vishal. He'll be giving you some of the very beautiful, tips on the X-rays. We are here also, we are working on the X-rays. How often we can go for the dental scalings, gap between the two scalings? It depends upon what you are feeding, but we always say that twice a year. After giving dental treatment, Dr. Vinay Varshney, after giving dental treatment, how many hours of gap should be there to give food to them? Again, once the animal regains the consciousness, offer them the fluid. Okay. But I always say that there are certain dogs who feel extreme pain post-operatively. And the only solution for alleviating the pain is to exercise a perfect dental nerve block. Once the dental nerve block is being given, animal, they definitely eat. Otherwise, they sometimes become anorexic for 1 or 2 days. Then you have to manage the pain. Dr. Himani is asking, will there be any session regarding? Yes, we will do RCT in the fourth one, endodontics, in the fourth webinar. So stick around, please. Always in general anesthesia treatment, yes, sir. The dentistry, unfortunately, is, we always prefer that should be done under the general anesthesia, because most of the procedures are in the general anesthesia. So try and do, if you want some tips on the anesthesia, so I can give you about the what kind of the anesthesia should be preferring for. I think in exodontics, I'll make 1 or 2 slides for that,
Yes,
for
yes,
your,
that is
for
required, sir.
ease.
That is required.
Yeah. So what if the periodontal, Dr. Manoran is asking, what if the periodontal pocket is more than or less 7 mm in depth? Are we supposed to take the scaler deep into? Yes, you have to, because the tooth, the gingiva has already lost the contact with the tooth. So you have to clean it, right? So I told in the last that when you clean it to the tip, which is 7 mm deep, you are doing a root planing. Right. Now, what happens is that when 7 mm depth is there, we clean the tooth, we clean the debris, then we go for the root planing. Along with the root planing, we go for the gingivoplasty also. So we try to give a suture on the gingiva. In the next lectures, I will tell you, we're going to suture so that gingiva, doesn't lose the attachment. So we are making an artificial attachment to the tooth there. Dr. Rohit, can you suggest handheld dent scaler, sir, which is good for the? I've already, mentioned in this. I think you can go search the net. A lot of Chinese products they are available. Dr. Simran, beyond the clinical symptoms, what typical behavioral changes you have noticed in dogs? Oh my God. This is very important question. And in the beginning, I told you that the animal will lose the playful nature. One, animal will lose its interaction. Lethargy would be there. Okay, won't respond, is not interested in anything. Then the saliva sometimes it keeps on sticking. So animal becomes choosy about the food. Those are the signs which are normally we should be looking for to get the oral pathology checked up by the veterinarian. Noble. Sir, is there a correlation between periodontal disease? Yes, 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 yes. Now, this is again a very good question and very important from the client communication point of view, Dr. Noble George. It is very good question that whether the periodontal diseases, they are having a connection with the systemic diseases like CKD, hepatitis. Yes, it is. This periodontal film is acting like a nucleus. And from here, if the gingival recession is there, if gingiva is bleeding, the bacteria, the toxins, they are getting access to the systemic circulation and they're going and settling in the heart with the causing the heart valve disease or endocarditis in the kidneys. So most common predilection site for the periodontal pathogens is we have done a very beautiful study on that, on pathogen study is the renal side. So all the dogs presented for the CKD, almost all of them, they have a dental issue and dental job has to be done. Dr. Ravinder, what are the suggested blood tests before dental extraction in cats? Well, you have to go for almost all the panel, the liver panel as well as the CBC platelets should be there. Okay, and the animal should be in those brackets. Now, this is again a very this thing. Sometime what happens is that diabetic dog or cat is there. Okay, you have certain limits. Like if it is 600 or if it is 300, you have to again repeat the test. If it is 600, you have to stop it. Okay, so try and get the main chemistry panel and the hematology panel for the cats before we go for the extractions, or because it is not only the extraction. Okay, so it is also the general anesthesia, plus you have to go for the CT and PT also, clotting time and the bleeding time also is once. If the CT and PT is delayed, it can result into the hemorrhages along with the platelets also. So, doctor, what are the suggested blood tests? So, can you tell something about CBCT? Yes, cone beam CT. Cone beam CT, I'm afraid in India nobody is doing, but abroad CBCT is being done, and I still wish that if we have such kind of machines and such kind of technologies, CBCT is very, very important from the point of view of treating the malocclusions, giving some cosmetic dentistry. CBCT is very, very important. Dr. Mahendra is asking which antibiotic more useful. Sir, my favorite is clindamycin. My favorite is clindamycin. So I'll give you two choices. If you ask two choices, I'll start amoxiclav. If it is a periodontal 4, then I'll go for the clindamycin, right? You can give cefazolin also, but clindamycin takes care. So I just forgot to mention that whenever you have fixed the dental scaling, please make the antibiotic umbrella 3 days before. The antibiotic should be started 3 to 4 days before you fix the surgery or fix the dental job. Okay. So Nitin, why there is need of nerve block if there's, yes, because, see, what is very important. Again, this question is very important. We have seen that animal is under general anesthesia. And when you touch the tooth with the periodontal probe, sometime there is a movement of the head. Sometimes there is a movement of the head, highlighting the fact that the exposed enamel dentine, exposed pulp cavity is highly, highly painful. That's why we have to go for the specific nerve block to alleviate the pain. And secondly, why to give it? To give it to have a preemptive analgesia 6 to 7 hours after you stop the procedure. Dr. Simran is asking, sir, ever you have observed dogs with severe or advanced periodontal disease developing neurological symptoms like seizures? See, seizures we have exactly not seen, but we have seen in those animals, those are having some kind of nephropathy. One, or because the oral pathology is so high and temperature has gone up more than 100, 405, there we are finding the seizures. Dr. Manoharan, okay, he's thanking Dr. Vishal. So, which analgesic anti-inflammatory medicines you suggest? So, yes. Again, a very good question. So, in difficult animals, I go for the ketoprofen patch. Okay, go for the keto. Again, a food of thought for Vishal. Ketoprofen patch, anti-inflammatory. I'm giving Carodil as well as the Milonex. Okay, but if the pain is more, I always prefer and go for the Butram, subcutaneous.
Utah.
Yeah.
Right, sir. I think this we have finished all the questions, queries.
Yeah.
So it's time to say goodbye. Dear esteemed colleagues, on behalf of entire team of Oriheal Life Sciences, I extend my heartfelt thanks to each one of you for attending today's webinar, Practical Tips and Advanced Techniques for Effective Management of ORO-Dental Cases. We are truly honored by the presence of so many dedicated veterinarians from across the country. Your active participation, enthusiasm, and shared commitment to continuous learning are what makes such knowledge sharing platforms meaningful and so impactful. A special note of gratitude to Dr. Adarsh Kumar for taking the time to lead today's session with such clarity and depth. Your vast experience and practical insights have undoubtedly added great value to everyone present. We sincerely appreciate your effort in sharing advanced techniques and real world approaches that will surely help us in our clinical practice. We look forward to continuing this journey of learning and collaboration together, and we are eagerly waiting for the next session. Thank you once again for making this webinar a success. Thank you so much, sir.
Dr. Vishal, and glad to have you here. And I am thankful to the people and to the vets, those have attended this. I hope it has served it has served the purpose, and
Yes,
must have given you courage to go for the dentistry, and slowly we will develop the things how we as we proceed.
definitely,
Thank
sir.
you so much.
Thank you. Thank you so
Thank
much,
you.
sir.
Thank you so much. Thank you.
Have a wonderful evening, sir.
Thank you. Thank you so much.